Welcome to AETCM, the Emergency Medicine channel. As part of that ECG course, today I am discussing about ST segment. We have seen how the ST segment is formed in ECG. Now we are going to talk about normal ST segment elevation, ST segment depression, all these things, and different causes for all these ST segment elevation and depression. ST segment is formed after the S wave. You can see here after the S wave, there is a flat line, then T wave. Okay, this is the PR segment. Normally, P wave, PR segment, QRS complex, then ST segment, then T wave. S to T, that is ST segment. So if you draw a line on the PR segment, that is an isoelectric line that should fall on the ST segment also. So PR segment is an isoelectric line, neither positive nor negative, the middle. So the ST segment also should fall on that line. If it is above that, you can call it as ST segment elevation. If it is below that, you can call it as ST segment depression. So it is produced by ventricular systole. During the systole, it can form. After the systole, it happens actually. Then this PR interval is on the same line of ST segment. If ST segment is above the PR segment, you can call it as ST segment elevation. If it is below the PR segment, you can call it as ST segment depression. Now, when you see a ST segment elevation in ECG, normally we all think that it is due to myocardial infarction, but there are some other reasons for that also. You can see the following slides. But the most important reason for ST segment elevation is myocardial infarction. So here what you are seeing in this ECGs, this is the PR segment. ST segment actually should fall here, but it has gone up. So this is ST segment elevation. Now here you can see the different types of ST segment elevation, or it may be due to the changes in the myocardium during your myocardial infarction. Initially you get a ST segment with tall T waves, then ST itself will elevate. Then after sometimes if you don't treat the patient, you get T wave inversion, ST has come down, and you can get a Q wave, then Q wave again deepens, then this will become normal. So here it was normal, then patient developed myocardial infarction. Then after sometimes this ST segment has come back to normal, but remaining that Q wave is remaining. That shows infarcted tissue or death tissue. That we'll not see now. We are only looking for ST segment elevation. So significant ST segment elevation means a new ST segment elevation at the J point in two contiguous leads. So suppose you get change in V1 and V2 has to be there. Suppose if the change is in V2, V3 has to be there. If the change is in V3, V4 has to be there. Like that, inferior leads, if lead 2 is there, then lead 3 also has to have same change. Like that, two contiguous leads with 0.1 millivolt in all leads other than lead V2 and V3. 0.1 is 1 small squares. So if it is this normal ST is here, 1 square you take, that is 0.1 millivolt. If it is more than that, it is a significant change. In lead V2 and V3, the following cutoff points apply. 0.2 millivolts in men more than 40 years, 0.25 millivolts in men less than 40 years, or 0.15 millivolt in women. LBBB also can have the similar type of feature, because if the patient is having recent LBBB, that can be shown as ST segment elevation myocardial infarction. That can be part of ST segment elevation myocardial infarction, but actually in the ECG we are not seeing ST segment elevation, we are only seeing LBBB. So either to tell ST segment elevation MI, we need to have ST segment elevation with elevation of troponin I and CKMB, whereas patients are having chest pain and new onset LBBB with elevation of cardiac enzyme, then also you can call it as acute myocardial infarction. So don't think that only ST elevations will produce in ECG will produce diagnosis of MI. Even acute onset of LBBB with elevation of cardiac enzymes also have a diagnosis of MI. Now, one more important thing, if ST elevation is there, but cardiac enzymes are not elevated, then it is not myocardial infarction. It can be sometimes vasospastic angina. If you give sublingual sorbitrate, these changes can reverse. So, ST elevation MI with elevation in the ST elevation with elevation of the cardiac enzymes, you can make a diagnosis of ST elevation myocardial infarction. If cardiac enzymes are not elevated, then it may be possibly due to vasospastic angina. A new onset of LBBB with elevation in the cardiac enzymes also will be under acute myocardial infarction. Now, this patient is having chest pain with ST segment elevation in leads 2, 3, and AVF. They all are inferior leads. So, ST segment elevation in 2, 3, and AVF. So, it is inferior wall myocardial infarction. If cardiac enzymes are elevated, then they are inferior wall myocardial infarction. If they are not elevated, we have to see what is the reason for that SCA segment elevation. You also can observe here there is ST depression in V1, V2. They are called as reciprocal changes. So reciprocal changes can be there in anterior leads when there is ST elevation in the inferior leads. When there is anterior wall myocardial infarction like ST elevation V1, V2, V3, you can see sometimes ST depression in 2, 3 AVF. They are called as reciprocal changes. They are actually ST depression in the opposite side of the leads. Now here what you are seeing is ST segment elevation in V1, V2 septal leads, V3 anterior leads. So anteroseptal myocardial infarction, this patient is having anteroseptal ST elevation. If CKMB and troponin I or T is elevated, you call it as acute myocardial infarction. If both are not elevated, this ST segment become normal after sublingual sorbitrate nitrates. So your diagnosis will be vasospastic angina. They are not myocardial infarction. To make a diagnosis of myocardial infarction, you need to have ECG changes with elevated cardiac enzymes. So even sometimes you can see ST depression also. Some patients you can see ST depression, TIVO inversion, but if cardiac enzymes are elevated, your diagnosis is myocardial infarction. Now this is the coronary. Depending on coronaries, you can have some ECG changes. I am not going to the details of that. So you should know the coronaries and where all it applies. You should know. You should remember. So this picture will help you in that. Now, depending on the lead changes in the ECG, like ST segment elevation V1, V2, it is due to septal. The artery involved is proximal LAD. V3, V4, it is anterior leads. The artery involved is LAD. V5, V6, apical area of myocardium is infarcted. Distal LAD and RCA is involved. One AVL, lateral part of the heart is involved. LCX is involved. 2-3 AVF inferior, 90% of RCA or 10% of LCX also can be involved. Like that, you can even make a diagnosis of which artery is also involved. That is also possible, but in a routine clinical practice in emergency room, you are not going to make any diagnosis on last part. This may not be important in emergency room. For you, whether there is ST elevation in some leads with elevation in the cardiac enzymes, that is most important. So suppose you have V1, V2, V3, V4 ST elevation, you can make anteroseptal myocardial infarction, provided that you need to have a elevation in the troponin I and CKM. Okay. Suppose you have changes in 2,3 AVF, elevation in the troponin I and or troponin T and CKMB. CKMB, if they are elevated, then your diagnosis inferior wall myocardial infarction. But if you know about proper orientation about the circulation, then you can even make a better diagnosis whether it is proximal LAD, LAD or distal LAD. Like that also you can make a diagnosis. Now, ST elevation in AVR coexistent with multi-lead ST depression indicates subendocardial ischemia due to oxygen supply or demand supply mismatch. So, left main coronary artery stenosis can produce AVR ST elevation, proximal left anterior descending artery, severe triple vessel disease, hypoxemia, hypotension, all these things can produce ST elevation in AVR. So, ST elevation in AVR is not very common. You can have this many problems which can produce ST elevation in AVR, but remember hypoxia and hypotension also can produce ST elevation in AVR. What you are seeing here is ST elevation in AVR. Normally, P waves are negative in AVR, ST segment, T wave, everything is negative in AVR. But here, ST segment is elevated in AVR. Okay. Now, Prince metal angina, I have already told, when there is chest pain, the patient can have ST elevation. You may falsely diagnose it as acute myocardial infarction. So, when you give sublingual sorbitrate, myocardial infarction, the pain will not be relieved, the ECG changes will not be relieved. If no change, then it is MI. If there is normalization after sublingual nitrate, then it is Prince metal angina. So, angina will be relieved by sublingual sorbitrate. Myocardial infarction will not be relieved. Moreover, in myocardial infarction, you can have elevation in the cardiac enzymes, CKMB and troponin I. In Prince metal angina, may be slightly elevated, but most of the cases it is not elevated. That is very important. Now, another condition which can produce ST elevation is pericarditis. Pericarditis can be due to viral pericarditis, uremic pericarditis, bacterial pericarditis, tuberculosis pericarditis, whatever it may be. There is a classical change which can happen in myocarditis, that is ST elevation. So, myocardial infarction and pericarditis also can produce ST elevation. But what is a change in this? So, normally ST elevation in myocardial infarction will be like this. Okay. But whereas in pericarditis, it will be like this. So, concavity is towards up in pericarditis, concavities will be towards down in myocardial infarction. Myocardial infarction, you can have changes in V1, V2, V3 like that, or 2-3 inferior wards, 2-3 AVF. That's all. You may get in V5, V6 in lateral wall, 1 AVL, V5, V6. But whereas in pericarditis, it's a universal phenomenon. So you are getting ST elevation in inferior leads, you are getting ST elevation in the anterior leads and septal leads. So it's a universal phenomenon. Everywhere you get ST elevation and concavity is towards up. So these are the two important findings of pericarditis induced ST elevation. Now, ST depression is on the opposite side. This is mostly a feature of ischemic heart disease, whereas ST elevation was a predominant feature of myocardial infarction. But both these conditions, whether it is ST elevation or ST depression, if you have elevation of the cardiac enzymes, then it is myocardial infarction. If ST elevation with elevation cardiac enzyme, you call it as ST elevation STEMI, ST elevation MI. If it is not like if it is if ST is not elevated and cardiac enzymes are elevated, then it is NSTEMI, non-ST elevation MI. So the difference is mainly cardiac enzyme elevation. If cardiac enzyme is elevated, then it is myocardial infarction. Whatever may be the change, if cardiac enzymes are not elevated, then it is ischemic heart disease. But both are having similar feature. One is complete obstruction of the artery and the tissue necrosis happens. But here there is a demand supply mismatch in ischemia. If you can improve the supply by giving sublingual sorbitrate, diltiazem, or taking some rest, patient may improve. Here we are talking about ST segment depression. So normally PR interval, PR segment, QRS complex, ST should fall on that isoelectric line. So that is very important. Here what is happening is PR segment, then ST is depressed. So ST does not fall on the line of PR segment. Okay. There are three important types of ST segment depression. Upsloping, here you can see here. So upsloping, that means it is like this. This is the PR segment. Upsloping ST depression. Another one is downsloping. So you can see here, this is the PR segment. See this, downsloping. So slope is towards down. Third one is flat, flat ST segment. Okay. In that, most important is this one. If you are seeing a flat ST segment depression, then that is mostly a feature of ischemic heart disease. Now here, because of the rapid rate, there is ST depression. This is called as rate dependent ST depression. Most of the time when you have a tachycardia, ECG paper will be going in a very fast manner in the machine. Normally it will get time to go like this, draw like this. But if the ECG paper is going very fast, what happens? It goes like this. So it will not get time to complete the line in a usual manner. So it goes like this. So that's why we are getting an ST depression. This is called as rate dependent ST depression, and it is not a serious problem. If you control the rate, this problem can be settled. Now, flat ST depression almost always indicates ischemic heart disease. Depending on the area, you can tell what type of ischemia it is. So here we have V3, V2, V4, V5, V6. So these are anterior leads, these are lateral leads. Okay. So anterolateral ischemia, anterolateral ischemia, and even you can see here inferior leads also you are getting some ST segment depression. Remember, if cardiac enzymes are normal, CKM, this condition also we will do CKMB and TROP-T. If both are negative, then it is ischemic heart disease. This is only ischemic change. If both are elevated, then it is non-ST segment elevation MI and STEMI. Okay. So cardiac enzymes are the most important thing. Whether whatever may be your ECG change, cardiac enzyme changes are very, very important. Here what you are seeing, ST segment elevation in 2-3 AVF. That means patient is having acute myocardial infarction in the inferior leads. So we have previously discussed about the reciprocal change. So what you are seeing here is ST segment depression in other leads. So that may be a part of reciprocal change. So ST segment depression in V1, V2 in ST segment, if there is ST segment elevation in inferior leads, it can be a reciprocal change. Now LVH also can sometimes, both LVH and RVH can produce ST segment depression. Here it is a downsloping ST depression. So you can see here very prominent R waves in V5, V6, and you are getting ST depression. So you get a very tall R wave. Following that, you get ST segment depression. So this is due to strain. This is called as LVH with strain pattern. Actually, there is no ischemia there, but there is a demand supply mismatch. That's why we are getting this change. So if you are in a hypertensive patient, if you are seeing this type of changes, you have to make a diagnosis of LVH with strain pattern. Without strain also you can get. If there is no ST depression, it is not strain. There is no strain on the ventricle. Now, RVH also can produce strain. Right ventricular hypertrophy will produce a predominant R waves in V1, then ST segment depression and T wave inversion. So, along with the LVH and RVH, also you can get ST depression. So, that is not ischemic change. So, we have discussed about one important feature of ST segment. Normally, it will be on the line with the PR segment. So, PR segment is taken as an isoelectric line. ST segment can either up or down from the PR segment. But if it is associated with elevated cardiac enzymes, then it is myocardial infarction. If ST segment elevation with elevation of cardiac enzyme, it is ST segment elevation myocardial infarction STEMI. If it is depressed or T-wave inversion with elevated cardiac enzyme, then it is non-ST segment elevation MI or NSTEMI. If ST segments are elevated, there is no elevation in the cardiac enzyme, patient improves with sublingual nitrate, then it is mostly vasospastic angina. If ST segments are depressed, T-wave inversions are there, there is no elevation of the cardiac enzyme, chest pain is there, then it can be ischemic heart disease, unstable angina. If very tall T waves in V1 and ST segment depression you are seeing in V1, V2, then it is RVH with strain pattern. Same thing you can observe in V5, V6, very tall R waves in V5, V6 with ST segment depression, T wave inversion is a feature of LVH. Thank you.